Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. Well, after a glorious time and a week in Hawaii, I'm happy to be back. Today is actually my birthday, so happy birthday to me. And no, I'm not telling you how old I am. That's going to be a well-kept secret for years to come. But we had a great time. I'm a little sunburnt, but I'm definitely ready to come back to work and well-rested. I actually unplugged. I never do that. I had my laptop with me, only opened it twice, so I'm pretty happy for taking a break. My husband makes me, so it's always good that you have somebody that knows when you need to unplug, relax, and just spend time with family. We had my nephew and his wife there. We also had my daughter and her husband, and then another friend that came with us. So it was a great time had by all. So today I'm going to do just kind of a quick kind of topic, and this topic is going to be about tips that you need for accuracy, compliance, and just making sure that you are doing the right thing by being on target for coding. And as we, the Codecast podcast, I know I talk a lot about auditing, but I need to talk more about coding and making sure that for those of you that are extrapolating codes from a medical record, whether it be an evaluation and management service, an op report, anything like that, you really need to take a step back, take a breath, and understand what it means about being accurate. It can, accuracy and the discipline of being accurate, and I don't want to call it laziness and not really paying attention, but it's basically taking shortcuts. You don't want to do that. So accuracy affects reimbursement, compliance, your revenue cycle, and you can make some mistakes and this is going to be how to avoid them if you're not careful. One of the things that I see quite a bit, especially when we do some report coding for practices, we do it a lot for cardiology, for cardiovascular services, for orthopedics, for OB-GYN, and for neurosurgery. And I've noticed that when we code it out and then the staff also codes it, I recommend that just so they can learn what did they come up with and then what did we come up with. I know it's tempting to rely on the procedure title at the top of an op report, but coding from the title, that's a shortcut, and that's going to lead to incorrect coding. Remember, the procedure listed in the heading, that's typically a general descriptor, or is the procedure that was listed at the time that the procedure was scheduled, the surgery was scheduled. It's probably not reflective, most likely it isn't, of the full scope or the actual procedures performed. So when you just look at the header or the title of the report, that is not where you code from. You code from report detail. Always read the body of the op report. You never know what else you'll find. You need to look for techniques, anatomical sites, and any additional procedures or uses of even devices that could affect code selection. You need to look on if it's access, where the physician started versus where they ended up. Perfect example this morning is I had someone that had a heart cath, and there was also a lower extremity angiogram. I said, well, is it for closure? And because they were trying to get the cath code 36245 and the imaging code 75710 for the lower extremity angiogram. And I said, well, where did you begin? And they said, why is that important? I said, because access for a heart cath, the 93458 code, again, 26 modifier if it's done in the facility setting, it includes introduction, access, and manipulating the catheter. And so you can't double dip there. And they said, oh, and I said, but was it a radial, so a wrist access, brachial arm? Was it on the other side where now they're looking at the contralateral or opposite side, extremity? What was it? Turned out it was exactly what I thought it was for. It was just a guiding shot to close the hole the doctor made, and you cannot code for that. So understanding some of those differences and not coding from the header, basically where it says, for this one in particular, heart cath, lower extremity angiogram, cath placement, and the right common femoral. Well, that's where they started. So you can't have the last two services, especially if the intent was just a guiding shot and not diagnostic. So understanding what you're looking at, think of orthopedic. I'll see sometimes where doctors are trying, or coders, I should say, are trying to get two codes. Let's say that you did a diagnostic arthroscopy and then you did a rotator cuff repair through arthroscopically, so through the scope. Well, to take a look-see and then to go in and complete the surgical portion of that through the arthroscope, you don't get both. The first one is basically to open, to take a look, to confirm the reason you scheduled this surgery, and then when you get into the major procedure, you don't get the first part of that. That's why it's considered a separate service, and that's what they call it that. So understanding those nuances and coding, not coding from the heading of an op report is important. Now, what about defaulting to hospital ICD-10 codes and shared EHR codes? Oh my goodness. So I had this one come up from a new Coding Corner client this morning, and I just want to shout out Angie. Thank you. I think this was a really good example. And her example was, this is an emergency room note, and in the HPI, the patient states she has a history of asthma with occasional flare-ups requiring a nebulizer. So the diagnosis code was J45.901, unspecified asthma with acute exacerbation, and they also try to code the acute pharyngitis unspecified J02.9. But I'm looking in the plan of care, I'm looking at the entire note. I see nowhere where the doctor said that the patient had asthma. The doctor didn't say it. All the doctor talked about was there's no acute secondary history and physical exam for the patient. We will, along with the IM Solomedrol, patient sitting on the bed drinking cold water, after about 30 minutes stating her symptoms for her nebulizer have markedly improved. She gets home treatments and we'll follow her in the outpatient if they worsen. That's it. There was nothing in there about what the patient said. So in that one, you actually have to query the physician and say, hey, you need to add an addendum, a corrected information or delayed information that this patient actually has asthma, not just say it's what they have because they said they do. How many times do patients come in and say, or pediatric patients in an urgent care, yeah, my son's been experiencing fever for 3 days. And they come in, they take their fever, and it's 97.4, even below what is normal, and the doctor still codes fever. But when they come into the practice today, and the doctor even says in the note, the patient's caregiver has said that there was a complaint of fever, but today the patient does not present with fever. Can you still code it? No, you can only code what you have on that day of service. So when office and hospitals also share an electronic health record, a lot of times it's easy to default to hospital-assigned diagnosis codes. But does this really reflect the provider's intent or today's clinical context of the outpatient visit? So you really have to watch your workflows and make sure that you are reviewing and validating diagnosis codes for each encounter, making sure that or ensuring that the codes used in the office setting are appropriate and supported by documentation from that specific visit. My good friend Christine Hall, she always says, what happened today? We don't want the cut and paste from before. I know some things pull forward, but you get credit for what you do today and what that patient's risk is today. Remember, that's all risk-based when we're talking about E&M services or any kind of evaluation and management services. Now, one thing I'm also noticing, especially since I audit, seems like 70% of my business now is auditing, whether it be auditing for businesses physicians, or for hospitals or for payers. I noticed that a lot of internal and external coders, they seem to skip right to the assessment and plan for medical decision-making or time-based coding, thinking that they don't have to take into account or review the history and exam. But you could be missing and risk missing critical context within that encounter today that could affect medical complexity, justify the time with the patient. And so when you rush to calculate either medical decision-making or time-based coding, and you jump straight to the assessment plan of the note without reviewing the entire note, then you definitely could be missing the validation of the documentation when choosing the level of service and making sure that time was well spent if that's what's being used. So as far as best practice on this, read the entire note for context and comprehension. The history and exam often can contain clues about comorbidities, risk factors, patient concerns that may be part of the that may elevate the level of service. So try to avoid some of these situations in your workflows. I know some people call them pitfalls, to make sure that you are accurately coding, you're supporting proper documentation and reimbursement, and it strengthens your compliance in coding and billing. And accuracy and precision matters. Take the time to verify and validate that documentation through the whole encounter, the whole op report, when you are choosing, your codes and leveling your service and extrapolating information from an op report from a coding perspective. Okay, well, that's it for me today, everyone. Hopefully everyone has a really good day, a really good week, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.